The oral mucosa is a mucous membrane lining the inside of the mouth. It comprises stratified squamous epithelium, termed oral epithelium, and an underlying connective tissue termed lamina propria. The oral cavity has sometimes been described as a mirror that reflects the health of the individual. Changes indicative of disease are seen as alterations in the oral mucosa lining the mouth, which can reveal systemic conditions such as diabetes or vitamin deficiency, or the local effects of chronic tobacco or alcohol use. The oral mucosa tends to heal faster and with less scar formation compared to the skin. The underlying mechanism remains unknown, but research suggests that extracellular vesicles might be involved. So the histology of oral mucosa. The entire surface of the oral mucosa is covered by squamous stratified epithelium. This is a highly organized avascular and semi-permeable tissue whose thickness and degree of keratinization varies according to the location in the oral cavity and the area's functional and mechanical requirements. An interdigitated interface connects the epithelium and the lamina propria. The undulating projections of the deeper layer of the epithelium, known as retapex, attach to the underlying papillary projections of the lamina propria. Between these two tissues, there is a non-cellular basement. To which the epithelium is tightly bound. The basement membrane provides support to the epithelium and connects them to the connective tissue. On light microscopy, it is seen as a line of demarcation between the epithelium and connective tissue of the lamina propria. However, it is better observed with electron microscopy that clearly shows the basal lamina, which is further subdivided into lamina lucida and lamina densa. Structure, histological structure of oral mucosa. So oral mucosa consists of two layers, stratified squamous epithelium and the deeper lamina propria. In keratinized oral mucosa, the epithelium consists of four layers. Stratum basal, basal layer, stratum spinosum, prickle layer, stratum granulosum, и stratum corneum. Basal, spinosum, granulosum, corneum. In non-keratinized epithelium, the two deep layers, basal and spinosum, remain the same, but the outer layers are termed the intermediate and superficial layers. Depending on the region of the mouth, the epithelium may be non-keratinized or keratinized. Non-keratinized squamous epithelium covers the soft palate, inner lips, inner cheeks, the floor of the mouth, and ventral surface of the tongue. Keratinized squamous epithelium is present in the gingiva and hard palate, as well as areas of the dorsal surface of the tongue. Types of oral mucosa. The oral mucosa can be classified into few types that differ histologically, clinically, and functionally. Lining mucosa, it is non-keratinized, stratified, squamous epithelium found almost everywhere else in the oral cavity, including alveolar mucosa, the lining between the buccal and labial mucosa. It is a brighter red, smooth and shiny with many blood vessels and is not connected to underlying tissue by retapex. Buccal mucosa, the inside lining of the cheeks, part of the lining mucosa. Labial mucosa, the inside lining of the lips, part of the lining mucosa. And masticatory mucosa. It is keratinized stratified squamous epithelium that is found on the dorsum of the tongue, hard palate, and attached gingiva. Specialized mucosa. It is localized specially in the regions of the taste buds, on lingual papilla on the dorsal surface of the tongue, contains nerve endings for general sensory reception and taste perception. So that's the types of oral mucosa inside the oral cavity. Suggest to outline such, once again, to focus on such terms, epidermis and dermis. So epidermis is the topmost layer of the skin. It consists of 4 layers from deepest to most superficial. Basal layer, spinosum layer, granulosum, stratum corneum. The stratum basale contains the regenerative cells of the epidermis and is sometimes called the Malpighian layer. Dermis. It is the fibrous layer of the skin immediately below the epidermis. This layer contains predominantly collagen, but also elastin fibers, which contribute to the pliability of the skin. Also contains blood vessels, nerves, adnexal structures like hair follicles, eccrine sweat glands, sebaceous glands, and other structures. The dermis has 2 distinct regions. The uppermost papillary dermis containing fine collagen fibrils, the thicker deeper layer which has coarse collagen bundles. So what are the main functions of the oral mucous membrane? The oral mucosa has a large number of functions of clinical significance. It acts as a protective, physical, and immune barrier from external stimulus and harbors minor salivary glands that secrete saliva, maintaining the wetness of the tissue and perceives and responds to the stimulus of temperature, touch, and pain. Mechanical stress is continuously subjected on the oral environment by actions such as eating, drinking, talking. The mouth is also subject to sudden changes in temperature and pH values. The mouth is also subject to sudden changes in temperature and pH values and must be able to adapt to it quickly. The mouth is the only place in the body which provides the sensation of taste. Due to these unique physiological features, the oral mucosa must fulfill a number of distinct functions. They are as follows: protection, secretion, sensation, digestion, improvement. Protection. It is one of the main functions of the oral mucosa, that is to physically protect the underlying tissues from the mechanical forces, microbes and toxins in the mouth. The oral epithelium acts as a barrier against these physiological and pathogenic stresses. It functions as a physical and an immune barrier to external aggressions and prevents the penetration of the oral cavity's normal bacterial flora that may cause infection. Secretion. Saliva is a primary secretion of the oral mucosa. It has many functions, including lubrication, pH buffering, and immunity. The lubricating and antimicrobial functions of saliva are maintained mainly by resting. Saliva results in a flushing effect and the clearance of oral debris and noxious agents. Saliva contains numerous antimicrobial proteins that help protect the oral ecosystem from infectious agents. The components like lysozyme, lactoferrin, salivary peroxidase, myeloperoxidase, and thiocyanate concentrations act as a defense mechanism in saliva. And saliva, it is that environment in which all organs of oral cavity located all the time. Sensation. The oral mucosa is richly innervated, meaning it is very good at sensing pain, touch, temperature, and taste. A number of cranial nerves are involved in sensations in the mouth, including trigeminal, facial, glossopharyngeal, and valgus nerves. The dorsum of the tongue is covered in specialized mucosa. This contains the presence of taste buds, allowing taste, and it accounts for around 15% of oral mucosa. Reflexes such as swallowing, gagging, and thirst are also initiated in the mouth. Digestion. Saliva is secreted from three pairs of major salivary glands: parotid, submandibular, sublingual, alongside many minor salivary glands. It also aids the initial chemical digestion of food as it contains the enzyme amylase responsible for breaking carbohydrates into sugar, so initial digestion immediately in the oral cavity, and improvement of mastication and chewing. Keratinized masticatory mucosa is tightly bound to the hard palate and gingiva. It accounts for 25% of all oral mucosa. It supports underlying tissues by resisting the loading forces exerted during mastication. Lining mucosa in the cheeks, lips, and floor of the mouth is mobile to create space when chewing and talking. During mastication, it allows food to move freely around the mouth and physically protects the underlying tissues from trauma. So that was the main functions of oral mucosa. And now we move to disorders and starts from disorders of keratinization. So different pathological processes lead to different changes in the oral mucosa. They are divided in three types: disorders of keratinization, exudative changes, and hypertrophy. Disorders of keratinization include para, hyper, and dyskeratosis. Keratinization, it is the process by which epidermal cells, keratinocytes, undergo maturation and differentiation as the cell migrates from the basal layer to the stratum corneum. There is gradual loss of nuclear function with eventual loss of nuclei in the stratum corneum, loss of cytoplasmic structures, and progressive formation of keratin filaments to form the cornified envelope. Parakeratosis definition: it is abnormal retention of keratinocyte nuclei within the stratum corneum. The presence of parakeratosis indicates that the epidermis has been inflamed or injured. Clinically, this is manifested by the dimness of the epithelium of oral mucosa. Whitish color can be. Hyperkeratosis. It is thickening of the epidermis due to thickening of the stratum corneum with normal epidermal differentiation. In normal skin, there is a loose basket weave appearance. In hyperkeratosis, there is usually thickening and lamination or compaction of the stratum corneum. Dyskeratosis. It is the presence of premature or altered abnormal keratinocyte differentiation. Histologically, the abnormal keratinocytes have increased accumulation of keratin filaments, leading to a hypereosinophilic cytoplasm and shrunken hyperchromatic nuclei. For example, they are small and dark staining. With malignant dyskeratosis, keratinization is immature and appearance of atypical cells are occurred, which is characteristic for the disease of Bowen and epidermoid cancer. Exudative changes in the epithelium are observed in inflammatory diseases. These changes include balloon dystrophy, vacuole dystrophy, spongiosis, acantholysis. Clinically, manifestation on oral mucosa is the presence of blisters and vesicles. Each of these changes independently happens seldom. Most often they reflect dynamics of an exudative inflammation of a mucous membrane of oral cavity. So one by one, definitions to all of these terms. Balloon dystrophy. It is faulty changes in the cells of stratum spinosum which increase. They are rounded, taking the form of spheres or balloons. As a result, colliquative necrosis of this section of the epithelium As a result of colliquative necrosis of this section of epithelium, the cavities are formed. So these cavities is filled with exudate, in which sail the homogeneous globular cells, which resemble balloons. Vacuole dystrophy. This is accumulation of liquid inside the cells of stratum spinosum and basal layers. Cells increase in size, nucleus is pushed aside to the periphery and changes its form and sizes. Then nucleus is decomposed, forming unicellular cavity. During the confluence of such several cavities, the cavities of larger size are formed. Spongiosis is mainly intercellular edema, abnormal accumulation of fluid in the epidermis, and is characteristic of eczematous dermatitis, manifested clinically by intraepidermal vesicles, fluid-containing spaces, juicy papules, or lichenification. So here you have this schematic representation of normal skin and spongiosis. I wish I could find similar schematic diagrams for vacuole dystrophy and balloon dystrophy, but unfortunately I did not find. So if accidentally some of you during your preparation to classes will find similar schematic diagrams of such uh, pathological processes, balloon dystrophy, vacuole dystrophy, it will be beneficial for me. So just say in a case. Okay, let's continue. Acantholysis. Acantholysis means loss of coherence between epidermal cells due to the breakdown of intercellular bridges. It is an important pathogenetic mechanism underlying various bullous disorders, particularly pemphigus group, as well as many non-blistering disorders. Acantholysis, it is the separation of keratinocytes within the epidermis due to the loss of adhesion between keratinocytes. Acantholysis occurs due to failure of the integrity of the intercellular intraepidermal cell junctions. This leads to separation of the epithelial cells with swelling of the epithelial cells, ballooning degeneration. In pemphigus folicis, there is acantholysis of keratinocytes just below the granular layer of the epidermis. In comparison, in pemphigus vulgaris, there is a separation in the basal layer leading to tombstone pattern of keratinocytes, where there is a retention of some but not all keratinocytes on the basement membrane. So clinically, acantholysis is presented as a bullous disorders, and here you have this bulla cracked, and that is acantholysis and histological structure of acantholysis. Epithelial hypertrophy is a thickening of the epithelial layer of the mucous membrane. The leading mechanism of this process is acanthosis. Acanthosis, it is diffuse epidermal hyperplasia, thickening of the skin, elongation of interpapillary outgrowths of the epithelium due to the proliferation of the basal and stratum spinosum layers of epithelium. So acanthosis is a thickening of the epidermis and elongation of the rete ridges due to thickening of the spinous layer. Enlargement of rete can be as well. Typical examples include chronic eczematous reactions. So right now we are talking about main pathological changes, pathological mechanisms that are typical for different diseases. But the main mechanism, so diseases can be different due to clinical presentations reasons, but the main mechanism of their development, it is actually that what we right now are talking. So I'm focusing on this acanthosis, acantholysis, balloon dystrophy, vacuole dystrophy, spongiosis. It is base for different diseases. Papillomatous as well. So acanthosis is often combined with papillomatosis. And papillomatosis, it is the hyperkeratotic and undulating appearance of the epidermis above the surrounding normal skin. Papillomatosis is associated with hyperproliferation of keratinocytes. Papillomatosis may be seen in viral warts, seborrheic keratosis, confluent and reticulate papillomatosis. And example of disease and papillomatose is acanthosis nigrans. These cases show diffuse verrucose and papillomatose plaque on the upper and lower lips. And here you have this schematic diagram about normal skin, epidermis, dermis, and acanthosis, thickening of the epidermis caused by increased number of squamous cells. So once again, I'm repeating, if accidentally you will find during your preparation for classes such schematic diagrams of this pathological process, balloon dystrophy, vacuole dystrophy, it will be very helpful for me. Classification of mucous membrane lesions. Right now we are on new part of the lecture, lesions. We have finished with pathological processes and now lesions. So in general, all pathological lesions, alterations in oral cavity are classified on primary and secondary. Primary, it is that appear on unchanged oral mucosa, and secondary develops as a result of transformations or the damage of the already existing elements. So primary are macula, papules, nodules, tuberculum, vesicle, bulla, pustule, cyst, blister. Few more can be here given to the list, but these are the main. Secondary, example, after erosion, ulcer, crack, fissure, scales, crust, scalligenization, excoriation, petechia, purpura, ecchymosis, and few more. But these are the main. The same is here. A thorough oral lesion description must include the following 9 items: size, length, width, height, number, single or multiple, outline, regular, irregular shape, surface, smooth, granular, verrucous, papillomatous, pebbly, cobblestone, base, pedunculated, sessile, nodular, dome-shaped, site, mucosal, intrabony, dental. Color: red, pink, white, red, white, combined, blue, purple, gray, yellow, black, or brown according to their prevalence in oral mucosa. Consistency: soft, hard, cheesy, firm, rubbery, fluctuant. Origin: acquired, non-acquired, and morphology or clinical appearance: primary lesions or secondary lesions. So such criteria should be taken into account when it goes about description of any oral lesion. Configurations of lesion refers to the shape or outline of the skin lesions. Skin lesions are often grouped. The pattern or shape may help in diagnosis, as many skin conditions have a characteristic configuration. Nummular lesion, round, coin-shaped lesions, also known as discoid. Linear lesion, a linear shape to a lesion, often occurs for some external reason, such as scratching, also known as striate. Target lesion, concentric rings, like a dartboard, also known as iris lesion. Girard rash, a rash that appears to be whirling in a circle. Annular, lesions grouped in a circle. So it is description of the shape of the lesion. And In detail, we proceed with primary elements of lesion, those that appear on unchanged oral mucosa. The first, erythema. It is unrestricted, without clear margins, redness of mucous membrane. Roseola, small round erythema with a diameter of 1.52 mm to 10 mm and special contours, observed in infectious diseases, measles, scarlet fever, chickenpox. Hemorrhage spots are caused by violation of integrity of the vascular wall. Their size is different. Color of spots depends on the degree of the composition of blood pigment and can be red, bluish, red, greenish, yellow. During praising, the bleaching of hemorrhage does not occur. Sometimes they disappear without a trace. So here it is erythema, here it is measles rash, roseola, the main element. Macula spot. It is the most common oral mucosal lesion of melanocytic origin. These small, solitary, well-circumscribed, and often uniformly pigmented lesions most commonly in adult develop most commonly in adult female patients. Any mucosal site may be affected by the lower lip gingiva and palate, and at the most any area can be affected, but the most common lower lip gingiva and palate. The most common. The color of spot depends on the reasons for its formation. Patch. It is flat, circumscribed skin discoloration. It is very large macule. A slight scale may or may not be present. However, it is not an elevated or palpable lesion. Vitiligo, secondary syphilis-related oral mucosal lesions, and severe drug-related pigmentations can be described as a patch. As well, pigmentations are outlined as a primary elements of lesion, but I did not put them in the list of lesions to be described. So just stop at this macula and patch. Papule. It is cavity-free, often infiltrative, tight, morphological element with which size is up to 5 mm, which rises above the level of the skin or oral mucosa. Size of papules can range from the size of a millet grain, miliary can be, to the size of coin, numula. Papules are polygonal or round-shaped. The surface is flat, conical or spherical, pointed, semicircular, round, bowl-shaped. The color is often red with different shades. Nodules that occur on oral mucosa barely rising above its level have a size of a millet grain to lentils, lenticular papules. In the case of merger of papules, plaque forms. During a reverse development, papules disappear without a trace. Papular rash on oral mucosa are observed in syphilis, secondary period, lesion, planus, acne, fungal infections, etc. So plaque, here you have the photo of plaque. It is elevated solid confluence of papules, typical for psoriasis, eczema, and schematic representation of plaque. Wheel. It is firm edematous plaque that is evanescent and pruritic, a heave, for example, urticaria demographism can be examples of wheel. Pustule is described as a purulent, pus-filled papule or vesicle. Different articles give different information. Some says that pustule it is papule, some says pustule it is vesicle. Pustules are usually creamy white in color but may be yellow or green. Although the presence of pus usually suggests an infection, there are many sterile pustules. These lesions are usually smaller than 10 mm but may be seen in any size. In the oral cavity, a pustule presents as a pointing abscess or parulis. Herpes zoster also produces pustules that eventually ulcerate and cause intensive pain. So here you have examples of pustules on the skin and examples of pustules in the oral mucosa. This is stomatitis vegetans, pathognomic symptom of patients with Crohn's disease. Piostomatitis vegetans, it has such a name, Crohn's disease or ulcerative colitis. Nodule is a circumscribed, elevated, palpable, solid lesion that is greater than 10 mm in diameter. A larger, deeper papule, for example, rheumatoid nodule or lipoma. Nodule size of can be with the size of hazelnuts to chicken egg and more globular formation, which is located primarily in the dermis and submucosal layer of oral mucosa, deeper layers of the skin. It has different color and density. Nodes can appear as a result of inflammation, tumor growth, as well as deposition of calcium and cholesterol in tissue thickness. Inflammatory nodules generated by the nonspecific and specific infiltration. In leprosy, syphilis, tuberculosis, fungal infections are rapidly increasing. They can disappear with the formation of ulcers, and later on its place the deeper scars forms because basal layer is ruined, deep layers of the skin. That's why they will diminish with the scar formation. So nodule. Tuberculum. It is any small rounded nodule or elevation. It is tuberculum. It is cavity-free, infiltrative element of hemispherical shape, size 5-7 mm, which is stagnant red or bluish red color, raised above oral mucosa. Infiltration involves all the layers of oral mucosa. It is in the development stage. Tuberculums are necrotized with ulceration and subsequent scar formation, or with the formation of scar atrophy. The tuberculums occur mostly in limited areas of the skin and oral mucosa. They have a tendency to grouping or merging. They occur as primary cells in chronic infectious diseases, lupus, tertiary syphilis, leprosy. So they are typical for such diseases. Cyst. It is nodule that contains fluid or semi-solid material. Example, acne, epidermal inclusion cyst. A cyst is a thin-walled, closed capsule or sac-like structure filled with fluid, solid or semi-solid material. Cysts have an epithelial lining. A pseudocyst is a similar lesion but lacks an epithelial lining. A mucous cyst develops when the mouth salivary glands become plagued with mucus. Most cysts are on the lower lip but can occur anywhere inside your mouth. There are two types of cysts. Mucocellae show up on the inside of your lower lips, your gums, the roof of your mouth, or under your tongue. Those on the floor of the mouth are called ranulas. These are rare but because they are larger, they can cause more problems with speech, chewing, and swallowing. So, ranula under tongue и mucocelia on the lips. Two types of cyst. Vesicle. It is papule that contains clear fluid. Small blister, we call it. Formation which is slightly raised above the surface of the skin. Cavity element with size from the pin head to the pear, 0.5 cm or less in diameter. A vesicle is an elevated, fluid-filled lesion covered by epithelium. It is a small bulla, less than or equal to 1 cm in diameter. It is bulla. An ulcer is a defect or disruption of the epithelial component of the oral mucosa. When a vesicle loses its epithelium, it presents as an ulceration or erosion. Vesicles are common results of allergic reactions such as contact allergy to latex or viral infections such as herpes simplex, herpes zoster, or chickenpox. So, vesicles are common for these diseases. Bulla. It is large, fluid-filled blisters arising from separation within the epidermis, intraepidermal blister, or below the basement membrane, subepidermal blister. So here you have this schematic representation: vesicle, small, blisters, and bulla, big one. Bulla is described as a fluid-filled, superficial, raised, circumscribed blister, form lesion greater than 5 mm or 10 mm in diameter, almost 1 centimeter in diameter. The fluid can be clear, serous, hemorrhagic, or purulent. On the skin, bulla is commonly associated with burns, frictional trauma, and allergic contact dermatitis. Intraoral lesions can be seen in pemphigus vulgaris, pemphigoid, erythema multiforme, epidermolysis bullosa, and Stevens-Johnson syndrome. So these are diseases for which bulla is typical. Abscess. It is cavity formation filled with purulent content, arises as a result of the collapse of the diseased tissue and merging of small pustules in one area of inflammation, with the localization in the mucosa and submucosal layer, boundaries clearly defined abscess. In the deeper layers, they may not clear. They can be smooth. So here we have abscess on the gingiva. Successfully, we proceed to secondary elements. They develop as a result of transformations or the damage of the already existing elements. After the first one, superficial epithelial defect, round or oval in shape with a diameter 0.3-0.5 millimeters, localized on the inflamed area of oral mucosa. After is covered with fibrinous coating, which gives the element of destruction white or yellowish color. On the periphery of after is a bright red rim of inflammation. Aphthous ulcers can be an early manifestation of systemic diseases such as Behçet disease, gastrointestinal disorders, including celiac disease, Crohn's disease, and ulcerative colitis. In some severe cases, after can transform in ulcers, Sutton's after. It is chronic, long-lasting after that is very hard to heal. The course is very long, 1 or 2 months. The exact reason why aphthous ulcer develops is not yet clearly defined. Approximately 40% of people who get aphthous ulcers have a family history of aphthous ulcers. Current thinking is that the immune system is disturbed by some external factor and reacts abnormally against a protein in mucosal tissue. So usually, after as element of lesion in chronic recurrent aphthostomatitis happens in patients who have some chronic systemic diseases of gastrointestinal tract. Erosion. Erosion is described as a red, shallow, moist, slightly depressed lesion that often results from a broken vesicle or bulla, epithelial breakdown, or trauma. Erosion should not be mistaken for ulcers, which are covered with fibrin coating and are usually yellow. Although erosions may develop into ulcers, it is important. They can transform into ulcers. Healing rarely results in scarring because the basal layer of the epithelium remains intact. So that is important. Every lesion that do not cross basal layer will resolve without scar. Every lesion who cross basal layer of dermis of epithelium, it will heal with scar formation. Pemphigus, lesion planus, erythema multiforme. It is that diseases that produce mucocutaneous erosions. Here you have irregular erosions on the upper lip. I by mistake wrote lower lip, so upper lip. And erosion due to chemical burning.
Professor, sorry, I disturb your explaining. Just one question. Please repeat again. If the lesion cross the
Basal.
basal layer,
Yes, if the lesion cross basal layer of epithelium, it will heal with scar. In the case of erosion, it do not cross basal layer. That's why scar will not form.
okay.
It is superficial lesion. Erosion after it is only in epidermis. It do not go into
Just I
dermis.
want to raise this point. Okay, okay. Thank you.
Okay. Ulcer. Actually, ulcer it is that pathological element that heals with a scar because ulcer cross basal layer of epithelium. So ulcer, the full thickness loss of the epidermis plus at least a portion of the dermis. So defect is localized in dermis. It may extend into the subcutaneous tissue. Ulcer heals with a scar. Ulcers are characterized by segmental or more extensive loss of epidermis, including the basement membrane with exposure of the underlying dermis. Erosion is characterized by the partial loss of epithelium with the basement membrane left intact. So that is the difference between ulcer and erosion. And here you have clinical presentation of ulcer on the lip and schematic diagram of how looks erosion, superficial defect, and ulcer, defect of a deep layers of the mucosa, penetrating basal layer. basement membrane. The center of the lesion is initially red and then turns gray. That is a clinical presentation. The center of the lesion is initially red and then turns gray-white after being covered with fibrin coating. The periphery of the lesion may be erythematous. Ulcers are further classified according to their depth, border, shape, margin, and the tissue at its base. Ulcers can be superficial or deep. Superficial ulcers shave less than 3 mm depth, while deep ulcers have over 3 mm depth. In terms of shape, the ulcers can be divided into symmetric and asymmetric forms, according to the degree of regularity of the borders. The margin of the ulcers can be smooth or crater-like when it is above the level of the normal mucosa, and actually crater-like appearance of ulcer indicates about its cancer transformation. Oral ulcers are the most common type of oral lesions, such as a recurrent aphthostomatitis, traumatic ulcers, because after can transform in ulcer. Erosion can transform in ulcer. So that is that diseases in which ulcer can be leading element. Fissure, crack. By the way, that is the schematic representation of fissure. As well, it involves deep layers of dermis crossing the basal layer. Fissure or crack. It is a split, crack, erosion or narrow ulceration of the skin or mucosa extending through the epidermis into dermis. In comparison to an oral ulcer, a fissure represents a deep groove or crack in the soft tissues rather than a loss of the top layer of tissue. So it is deep groove. Presence of a fissure can indicate a condition representing a normal variation or a disease. But I'm stopped only on diseases. So diseases associated with fissures occur when pathogenic microorganisms, mostly Candida albicans, colonize a normal fissure, commissure of lips. Here we have. But in patients who have low immune system or who have problem with level of occlusion, these commissures overclosed. So Candida albicans, as an opportunistic infection, can colonize this area, leading to such disease as angular cheilitis. So angular cheilitis. In these patients, there will be pain, ulceration, and of course inflammation. Another disease that is associated with fissure formation, it is chronic lip fissure. Chronic lip fissure represents a persistent linear ulcer in the sagittal plane of the upper or lower lip vermilion border. Chronic lip fissures have been reported more often in males than females, possibly due to bad habits. It is associated with pipe smoking, biting on some subjects as a habitual hazard, or playing on some wind instruments. So that is the possible reasons of chronic lip fissure development. Chronic lip fissure is a precancerous lesion. Everything that cross basal layer and is located in deep layers of dermis eventually could develop in cancer due to chronic contamination by microorganisms as one of the leading mechanisms. But it will be another lecture. Okay, so chronic lip fissure. Crust, another element. It is dry concretion of parakeratotic keratinocytes, serum, and inflammatory cells within the stratum corneum. It is dried serum, pus, or blood, usually mixed with epithelial and sometimes bacterial debris. Process is called crusting. So it is the result of plasma exuding through the eroded epidermis. It is rough on the surface and is yellow or brown in color. Bloody crust appears red, purple, or black. In erythema multiforme, acid hemorrhagic crusts may cover the labial lesions, and a fibrin whitish coating may line the mucosal erosions of the cheeks or palate. So, after vesicles pop, there's ulcerative surface, and this ulcerative surface can later be covered by crusts. So erythema multiforme, it is that disease where crusting is typical, bloody crust especially. Scales or scale crust, such term, is localized areas of stratum corneum where there are parakeratosis, inflammatory cells, and serum that arise from inflammatory skin disease. For example, infected eczematous skin conditions. Example, exfoliative cheilitis. That is a typical disease where scales are formed. Eczema on the lips, also called lip dermatitis or eczematous cheilitis, causes a characteristic redness, drying, scaling on the lips and vermilion border. Skin of the lips and vermilion border. Eczema refers to a group of skin conditions that can cause itchy rashes, cracked skin, and painful blisters. So scales typical for eczematous skin conditions and inflammation of lips, cheilitis. Scar. It is fibrous tissue replacing normal skin in areas of healing. There are hypertrophic and atrophic scars. Hypertrophic keloid scars occur after trauma and surgery. They have a linear form, dense, often limit the mobility of mucous membrane. Hypertrophy explains that some component of the skin, such as the scar, is enlarged or has grown excessively. Atrophic scars, formed after healing elements of tuberculosis, syphilis, lupus erythematosus. Vegetations or keloid scars, it's like synonyms, but in our Ukrainian classification of pathological elements, we call it not hypertrophic scars, not keloid scars, but vegetations. It is a result of an overgrowth of granulation tissue at the site of healed skin injury, which is then slowly replaced by collagen type 1. Keloids are firm, rubbery lesions or shiny fibrous nodules and can vary from pink to the color of the person's skin or red to dark brown in color. And interestingly, healing of mucosal wounds occurs faster than skin wounds, and clinical observations have indicated that mucosal wounds rarely scar. We proceed with lichenification. It is caused by chronic rubbing, which results in palpably thickened skin with increased skin markings and lichenoid scale. It occurs in chronic atopic eczema and lichen simplex. So chronic atopic eczema and lichen simplex chronic. Excoriation. It is loss of the epidermis and a portion of the dermis due to scratching or an exogenous injury. It may be linear or punctate. Linear or punctate. It may also be referred to as a scratch. Excoriation presents as well-defined injury with sharp or linear edges, most often located on the extremities. Excoriation may also be a sign of factitial dermatitis. Factitial dermatitis is a term for self-inflicted skin injury, which is often identified as linear wounding that occurs in areas within reach, such as the abdomen, anterior chest, face, or extremities. Purpura, petechia, echymosis. They refer to bleeding into the skin or mucosa that results in violet or purple discoloration that varies based on its duration and does not blanch with pressure. Purpura can be divided into two categories of petechia and echymosis, according to the size of lesion. Petechia is defined as tiny 1 mm, 2 mm pinpoint non-blanchable purpuric macules resulting from the rupture of small blood vessels and can be red, purple, or brown in color. Echymosis is also described as a non-blanching purpuric macules greater than 3 mm in diameter due to extravasated blood in the skin or mucosa. Over time, the color may change from blue-black to brown-yellow. By the way, in two different articles, this pathological element, purpura, was positioned in different places. In one, it was positioned in primary elements together with macula spot. In another article, this element of lesion purpura was positioned in secondary elements. So I don't know actually how it's supposed to be, so I put in secondary elements. But it belongs to macula, to spots. No, I don't know actually uh, how to position this element. Anyway, we proceed. By the way, purpura is typical for thrombocytopenic, idiopathic thrombocytopenic purpura disease or any other hematologic diseases. So purpura, petechia, echymosis, hematoma, telangiectasia, all of these elements are typical for hematologic disorders and their oral manifestation. Telangiectasia, it is spots that appear as a result of a steady, non-inflammatory vasodilatation or neoplasm. They formed a thin, winding vessels that can split together. During pressing, telangiectasia stays a little pale. They are usually harmless, but may be associated with several diseases. Example, idiopathic thrombocytopenic purpura. Hematoma. It refers to collection of extravasated blood, relatively or completely confined within a space. The blood is usually completely or partially clotted, and according to the lesion duration, it may manifest various degrees of organization and color. Post-dental extraction hematoma and hematoma due to local anesthesia are among the most common complications in dentistry. Moreover, post hematoma due to local anesthesia is very dangerous in patients who suffered thrombocytopenic purpura, as it can transform into phlegmona, and phlegmona, it is life-threatening condition, especially in that patients with low immunity, those who have diseases of blood. Okay, granuloma, it is a type of inflammation characterized by histiocytes. Here I put photo from pyogenic granuloma because it is the only possible representation of granuloma in oral cavity, pyogenic granuloma. And about this disease, I will in detail speak in a lecture that is devoted to precancerous lesions. Granulation tissue made of a mass of new capillaries and fibrous tissue in a healing wound. Unfortunately, I did not find something special, just similar, a granulation tissue. I don't know if it is true or not, but it's granulation tissue looks like. And finally, we come to classification of mucous membrane lesions. This classification was suggested by Professor Borowski from Kyiv University and unfortunately Mashkilayson, Moscow University. And according to it, we have traumatic lesions, mechanical, chemical, physical trauma, infectious lesions, virus diseases, bacterial infections, Vincent stomatitis, venereal diseases, candidiasis, allergic lesions, medicament intoxications, oral mucous membrane manifestations of some systemic diseases, hypovitaminous, endocrine disease, alimentary tract disease, cardiovascular, blood disease, nervous system diseases, and other diseases. And changes of oral mucus in the dermatosis with autoimmune component, tongue anomalies and diseases, cheilitis, precancerous diseases. Actually, it is the classification of mucous membrane lesions, and that is that, like a timetable of your classes. All of that you will study during this subject, oral mucosa pathology. In conclusion, such statement. Oral mucosal lesions may occasionally diagnosed correctly, based on a brief history and clinical examination. Therefore, an accurate description is essential for diagnosis and management of oral lesions. As regards, continuous observation and monitoring of the lesion is required. An acceptable description of lesion would be critical for comparison purposes. When biopsy sample is taken, the pathologist needs an accompanied lesion description to reach a definitive diagnosis. Since questions about the management of lesion may arise, documentation of the description is necessary and should be included in patients' records. Actually, lack of detailed description of oral lesions can lead to difficulties in prioritizing the oral medicine appointments. So that's why the importance of the general appearance of lesions is so critical. First of all, for diagnosing correctly and um, for later biopsy diagnosis and comparative diagnosis, and of course for later medicament management. So that is the purpose of this lecture and conclusion actually. So that's all. Thank you. By the way, references. I did this lecture using search on Google search. Sometimes it was PubMed documents, sometimes it was ResearcherGate documents, and Science Direct documents. The most important articles here I put as a reference. So it was histology oral mucosa, stat pearls. It is PubMed article, oral lesion description, mini review. It was International Journal of Medical Reviews, ResearchGate, and tissue-specific immunity. It was as well PubMed article.
Thank you, Professor.
Thank you as well. Okay, I have such intention to send to you this lecture so you can use it in your preparation for classes, but I need to do it first. I need to save it in PDF, prawda?